Welcome to Closing the Gap, a podcast where we discuss unmet medical needs around women's health with experts from different disciplines. My name is Antonella Santuccione Chadha. I am a medical doctor and I'm specialized in the field of neuroscience, psychiatry and neurology. I am the co-founder of the Women's Brain Foundation, an organization that focuses on sex and gender precision medicine with a special focus on brain and mental health. In my field of work, the same question keeps coming up. Why do women and men fall sick in different ways? And why is this still so rarely taken into account in treatment, in clinical development, research and care? In the field of brain and mental health, the differences are pronounced. Women are more often affected by conditions like Alzheimer's disease, depression, migraine, anxiety disorders, multiple sclerosis. For instance, in Parkinson's disease and strokes, women often experience symptoms in a different way than men. The Women's Brain Foundation is advocating for a healthcare system that consistently takes women into account. We need to close the gaps in knowledge, in research, in treatment and care. I would like to take a moment to thank our partner Assura. Assura is health insurance that is committed to women's health all over Switzerland. Their main focus is prevention and early detection. Together we are sending a clear signal: women's health deserves our full attention. In this episode, we focus on perimenopause and menopause. Almost all women between the ages of 40 and 60 are affected. At this stage of life, many women are in the midst of their careers, they are mother to children, they are partners or wives, and they are caring for family and friends. At the same time, not only their bodies, but also their brains are undergoing changes. I will talk about all this with Dr. Valentina Vinante. She's a gynecologist, a researcher, and she's also specialized in preventive medicine. And I can proudly say that she's also a great supporter of the Women's Brain Foundation and the work we do. Valentina, I am delighted to have you with us.
Ciao Antonella, I'm very happy as well and glad to be here today. So as you said before, I'm a gynecologist and I'm working mostly with women, but I have also a degree in preventive medicine. And my goal when I work with my patient is really to combine both my knowledge in gynecology, but also the preventive medicine, to really think forward with my patient. As you said before, the theme of today is menopause and perimenopause. I have a gynecological practice here in Zurich where I work with women actually from 14 until, let's say, 70 or 80 years old. But at least 1/3 of my patients are perimenopausal and menopausal women. So it's something that I see mostly every day.
I find it very fascinating, the fact that you mentioned prevention and all those hormonal transformations that characterize the life of a woman. Can you please explain, first of all, to us what it is menopause indeed, in simple terms, what happens to our body? And please elaborate on this one.
So this is a big question, and menopause is actually a condition, not a disease. And I really want to underline that. And it's characterized by many different symptoms. Women are different, and every woman may experience a different type of
Correct.
Perimenopause and menopause. But first of all, let's go to the cause of menopause. That is basically a sudden or slower change of hormonal balance in our body. We are going through an aging process, and also our ovary are getting older. What does it mean? That we will have less follicle or less small structure that produce an hormone called estrogen. And this estrogen decrease has an effect all over our body. You know better than I, we have estrogen receptor all over our bodies. And now
This is why I was mentioning the word body. What does it mean exactly?
Exactly, because the women, and I really want to go to the core symptoms of menopause first, they normally come to me with different kind of symptoms. They can be related simply with the change in the menstrual cycle. That's the first symptoms normally, where they notice that their cycle, instead of being every 28 days...
One thing.
Yes.
When is it the typical age? The women that face menopause, how old are they in most of the cases?
It's a very interesting question, because until a few years ago, we just said, okay, menopause women are around 50 or after 50. Now, finally, there is much more awareness around the symptoms. So actually, many women come already around 45, 43, because already there you can see the decrease in hormone. So like actually the effect of the hormonal decrease. And very, very often the first symptoms is actually a brain health symptoms, and it's normally sleep problem. And it's very fun that I say that, but I see all these women come to me and say, you know what, I cannot sleep well. And then now I'm used to say, tell me, are you awake around 4 o'clock in the morning? And it's really this typical 4 o'clock alarm clock that is typical of the sleep disorder in menopause. And for me, super interesting because I could basically start really to put down data about this. It's not at 11
because
o'clock.
Because we don't have yet enough data to understand why this happens and how to help these women. Is that correct?
Yes, exactly. And it's really interesting to really see this pattern, because other kind of disease that creates sleeping problematic, probably women say, I cannot fall asleep, or I'm agitated, but really this 4 o'clock
thing 4, 5 o'clock, correct,
is the typical one.
Yeah.
And then we have women that comes as well with other brain health symptomatic, and it's brain fog and concentration problem. So they come to me and say, actually I'm feeling well, but I cannot concentrate. Probably I'm tired because I have 2 or 3 children, because I'm working a lot, but my brain function differently. This is probably one of the main early symptoms, together with cycle disorders. So normally women have a cycle that lasts in between 26 and 32 days, and they start to say, if I have, or if I write down in my cycle calendar or my cycle app, I can see that now sometimes I have every 21 days and sometimes every 35.
Which brings me to one remark. You mentioned something very important, in my opinion. It is this calendar. I think that what patients, women that goes through this phase should really do, it is to note down this change in their sleeping pattern, in their concentration pattern, to really objectify this observation for a medical doctor, for someone who might help them. And we go back to this point later on, why this is important, because not every doctor has the knowledge, neither the approach that you might share with us today. And it's not a critic, it's just that, there aren't so many gynecologists who are very sensitive to the topic. There aren't enough data. There is a bias, as we know, in medicine. And I think this is why it's so important that, they write down, they bring the evidence with them.
In perimenopause, early menopause, the most important thing is educating our patient or creating awareness. And now it's super easy, actually, to write down a calendar. There are really women that write it down with a pen, and I find it very important, also this writing activity. But now there are really many apps. And I tell to my patient, please try to write down what's happening to you. Look if it's more just in the second part of the cycle, first part of the cycle, what's going on. Because, for example, sleeping disorders, especially in perimenopause, are mostly before the period is coming, where you really have a drop down of both estrogen and progesterone.
Very interesting.
So you can, once you have a calendar, and I always say try at least to do it 3 to 6 months, it's easier to tackle the problem. And you can really help a lot. I can really see a big difference when we know exactly what's happening. And then we say, okay, now we can really act there.
Which means this is really a precision medicine approach. You are really trying to help the patients with the evidences that are really specific to this individual based on the symptoms at a specific time of their still menstrual cycle, because they still menstruate, of course. That's the perimenopause, right? What about the other symptom that I often hear, which is weight gain or change in the mood? Can you maybe tell us what's going on in that direction?
Changing in the mood, I see it quite often. And as well, it can be hormone-related or is hormone-related as well, because this abrupt change in our hormone balance has an effect on our brain and our brain receptors. So women became more, there are actually two things that I see a lot in my patient, and it's like, either they tendency can have more a kind of an aggression feeling. This is one, or the one that are more sad. So you really
sadness and aggression
together with anxiety.
Yeah,
anxiety is extremely present. So it's like one of the things that my patient report mostly. And naturally weight gain. We know actually that estrogen has an effect also on our insulin, insulin resistance. So if the estrogen is lower, then we have tendentially more insulin resistance. Insulin resistance means not only weight gain, but also a higher risk of cardiovascular disease. So we really have to be to pay attention also to it.
This is the axis between brain, heart, and I will say the reproductive system, right? That it's often not very well addressed from treatment approaches, etc. So we spoke about the symptoms, the most common.
Can I add one more? Because I think it's more common than we think. Is actual skeletal pain.
Absolutely important.
And sorry for interrupting you, but 60% of women report this kind of symptoms, and they have pain everywhere, in the hands, in the shoulder, and sometimes before having the right diagnosis, that can be simply related to menopause, because we know estrogen go to our articulation and basically help our cartilage to build up and increase the liquid in our articulation. We know that many women go and seek for help to orthopedic doctor, to rheumatologists. Sometimes they start to take very intense therapy treatment, while basically they simply need to know, okay, I'm going through menopause or perimenopause, and I may need simply something different that is not so actually strong.
And I assume that this goes also then together with the initial process of osteoporosis, right? Does it link to that?
Yes. In a way, we know that is more a risk of hormone depletion. Women don't feel the symptoms of osteoporosis. Of course,
it comes very late.
Comes very late. Now I started to do even more osteoporosis check in the practice after a certain
which means,
age.
Super important. I'll recap now the symptoms.
Yes.
You had those that I might have forgotten. Now, we spoke about the symptom of menopause. The next part is going to be what to do about it. I mean, how do you manage your patients? How do you guide them through this transformative phase of their life? And also why we have women that have it more and women who have it less. So let's recap. The main symptoms of perimenopausal changes starts around 45 years old, and we can summarize them with sleeping problems. That starts as one of the first symptoms. Then we have change in
mood.
In the mood. We have weight gain. We have loss of the muscle structure
and muscular pain and hot flashes as well.
Hot flashes we forgot. You see, I mean.
But it's interesting because until a few years ago, everyone was just speaking about hot flashes. Yes. And now we saw, okay, they may be there.
And I have a question now. The hot flashes, when do they enter in the history of those, let's say, changes? Because I found interesting that you mentioned first sleep. When does hot flashes start?
Later. When the hormone depletion, it becomes more chronic. Nice. Because in perimenopause, you have phases where your estrogen is still good, but phase where it's really down. So you compensate. And we know that now that is really new, actually, that hot flashes have two causes. One comes from the brain. There is candy neurons, actually, that regulate our temperatures. And we know that estrogen has receptor exactly there. So we know, actually, that there is a central thermal regulation of our body. And the second reason why we have hot flashes is because estrogen goes to our blood vessels. And the loss of estrogen decreases the elasticity of our blood vessel. So the blood vessels become more stiff, so they cannot adapt anymore to temperature changes.
It's super interesting. So it's really, we go back to the beginning of our conversation. It's about a change that impacts the whole body of a woman. It's not just the reproductive organs as it used to believe in the past or the hot flashes. And it's also interesting that it came at the end of all the symptoms we've listed, because actually they are maybe the less dangerous one in a way, because if you don't sleep well, I think it has a much more profound impact on your performance, on your life, than if you have once in a while hot flashes or the sleeping, the sweating during the sleeping. I think that pain in the joints, that weight gain, or as we said, sleeping disorders might be more profound than just having the hot flash. That said, what do you do? I mean, when a woman comes to your attention, or when a woman has to go to a doctor's attention, what does she... Let's make this exercise. Let's now be in the shoes of a patient. What does the patient has to ask to a doctor to be done, to understand where she is in her journey about menopause and perimenopause?
Women can go either to a family doctor or a gynecologist. Sorry, I just make a small parenthesis. We gynecologists are actually the first gate quite often, because women come regularly to us, normally once a year or once every 2 years for the regular checkup.
Do you ask proactively to the patient, or...?
I'm proactive, meanwhile, because I critically say the way we normally do the prevention checkup is super old school.
This is your prevention medicine approach.
Yes. And proactively, we give a questionnaire to our women that may be there. So starting from 40, 45, we already start to see the symptoms that they have. And then when the patient comes to me, I go with the patient through the questionnaire that actually are normal questions about the symptoms that we just spoken about. And I find it's a
little triage tool to orient your discussion later on. I find it phenomenal. While the patient waits outdoor, you already gain information about the history of this person.
Yes, and it helps also the patient to reconnect.
Absolutely.
And say, okay, how do I feel? I'm really going through it or not?
Absolutely.
And then we do the normal, anamnesis, a patient history, with the help of the questionnaire. And already there, we can find out many things. Based on that, we can do a tailor-made prevention. So we, for sure, as gynecologists, we do the breast check, we do the pap test and so on, but then we can say, okay, you may have problem now with your hormones, so you may have problem now with weight gain and so on. So I'm really proactive in also prescribing blood tests, because if I see that a woman has a high cardiovascular risk, also with the family history, I don't wait until she's 60 to check the cholesterol. I say, you know what?
That's so important.
Let's check it now. Or I work sometimes with few cardiologists and we do cardiological check. Or we do a lot of lifestyle plan.
Actually, I just read also that about cholesterol and the connection between menopause and heart diseases. Even anxiety and stress are proven to increase the risk of cardiovascular events around menopausal women. And we go back to what you said before, that estrogen have a very neuroprotective but also vascular protective role. And that's why when menopause happens, the increase for cardiovascular event in women also increase. And so very, very important that the cholesterol, that the risk for heart disease is assessed by gynecologists as well. And I'm talking not only about LDL, HDL, but also lipoprotein A1 to understand whether this person has really have a strong predisposition to heart attack or family histories also. Please, just wanted to, because it just got released in a recent published guidelines by the Congress of Cardiologists in Spain. Sorry.
I just spoke with a cardiologist about it.
So you can elaborate on that, please. You might know
but
more.
It's really interesting because actually when I was in the US, and we're speaking about 15 years ago, I actually worked with a professor at Yale University who was big into menopause, and he was working with a group of cardiologists showing actually that hormone depletion increased the risk of cardiovascular disease. And it was we could go through big studies that have been published about hormone replacement therapy and not using hormone replacement therapy and the increase of cardiovascular disease. But that's why I'm saying, going back to our patient that come to the practice, it's super important to say, okay, which kind of risk do you have? And just because you're going into menopause, your risk is even more increased. So let's check, because there are patients actually that comes and they are doing perfectly fine, Antonella. They eat properly, they exercise. They may have some symptoms, but we know, okay, these patients actually are well informed, they do everything right. So we actually don't have to put too much energy or to over-diagnose things that are not there.
Absolutely.
But there are certain patients, actually, that are probably, as you said at the beginning, like hard worker, career women, probably with children that don't have time for anything. And then they don't think about their health. And suddenly you ask, okay, do you have anyone in your family with cardiovascular disease? And they say, yes. Mm-hmm. And I don't have time to exercise. Mm-hmm. And my weight is actually 5 or 6 kilo more than it used to be. These patients are the ones that need help. And actually, they're also open for it.
And I was also, surprised to learn that there are some women that, although they've reached the age of 40, 45, they're still with contraception going on. What do you think about that? How does the contraceptive method has to change in the adulthood or the perimenopause phase of a woman? Because this is also something very much not spoken.
It's like a big theme. So there are very clear guidelines about it. And I'm happy so that we can all work like kind of in the same way, but there are like different kind of contraception. There are the one that increase the risk also of thrombosis and emboly, right. And we know that we can give them maximum to women that are 40, really maximum when they don't have any cardiovascular risk. Then we have to change after 40 by definition the contraception method, and there we have to use like pills with just progesterone derivative. When do we have to stop contraception? Actually, until a woman has a period, contraception is indicated.
If children are not planned.
Exactly. That's super important. And then, actually, I'm very happy because we can really do a tailor-made contraception method combined with hormone replacement therapy now, meanwhile. And we can find really, based on the women that we have in front, say, okay, you are sexually active, you have good libido, but you already have children, or probably you have not, and you don't want any more. You have symptoms. So how do we help you with your symptoms, but also with contraception? And actually now we have very good solution.
You touched a terminology that has a lot of controversy, but it's really highly debated, HRT replacement therapy, so hormonal replacement therapy. You also mentioned progesterone. Let's elaborate on this, what we should do when, and by whom it's highly recommended, by whom it's maybe not highly recommended.
Hormone replacement therapy is as well a big subject. Normally we start quite early meanwhile. So when women have symptoms, the symptoms that we mentioned before, exactly, why not helping? First, we work a lot with lifestyle because I always say to my patient, hormones is like the top of the iceberg. So first, be healthy. So, and going back to hormones, I use guidelines. So that's really important. So we don't experiment. We normally start with progesterone. Progesterone, why? Basically to regulate the cycle and to tackle sleeping disorders, especially in the second part of the cycle. Progesterone, even though it's a fantastic hormone, may not be enough, especially for cycle regulation. So we can also use hormone replacement therapy with not bioidentical.
Progesterone, it is an hormone that it's also produced by our body normally and also during pregnancy. Just maybe you want to elaborate on that and then we continue that people know what it's.
So progesterone.
Progesterone,
sorry, Antonella.
Sorry.
Progesterone actually is an hormone produced from our ovary in the second part of the cycle, so after the ovulation. If we check our hormones, because many women come, I want to check all my hormones. In the first part of the cycle, I'm not supposed to have progesterone or little concentration, but just after ovulation, the follicle transforms itself in a different gland, in corpus luteum. In German, it's called Gelbkörper, because it is actually a yellow structure, and it's super beautiful. If you check really in pathology and you see the ovary open, you see this corpus luteum, and it's produced in the second part of the cycle, and it increases the endometrium dimension. And as well, progesterone goes all over our body as well in our brain and produce a status of tranquility.
Correct.
And it helps women to sleep better, and it gives kind of a stability. Progesterone is the hormone of pregnancy, actually. If a woman gets pregnant, then progesterone will still produce from our corpus luteum and then from our placenta. But if we don't get pregnant, the corpus luteum stop to work, and then the progesterone fall down. In this case, we start to have our period again. Progesterone, as I said, is very, very good in early menopause, so in perimenopause, really to give a rhythm to our cycle, to tell to our body there is still a second part of the cycle, basically, like to help a little bit to move on. But sometimes it's not strong enough. And in this case, we need to use a progesterone derivative that is a little bit more stable, especially for women that have period irregularity. And in this case, when they say, okay, I cannot leave anymore because I don't know anymore when I'm bleeding. If I'm bleeding very strongly. We first try with progesterone. We see how it works. But if it's not enough, we can change. Then what happens if the women start to say, yeah, but I still have the symptoms. Actually, I cannot sleep as well in the first part of the cycle. I feel anxious. My brain fog is there and I have pain in the articulation, then we can already start estrogen. And it's interesting as well because until a few years ago, in the guidelines, start estrogen when the women have vasomotoric symptoms, so with hot flashes.
Now we start. Too late.
It's too late. Yeah. So now, as soon as we notice, okay, she may need a little bit of estrogen, we start. And we can really see the difference. I can see my patient after 3 months, they say, finally, I can sleep. Finally, I don't have pain. I can work better again.
Can the concentration of this hormone be measured and monitored during this therapeutic approach?
Yes.
Can it be done?
Even though I'm very critical about it, so we do normally, when I say we, I always say gynecologists and guidelines. Normally we do a first check at the beginning to really see if there is a link in between symptoms and hormones. And we normally check in the first part of the period and second part of the period because, as I said, the hormones are different. But after we start the therapy, many women want to check their hormones basically every month. But I always say to my patient, first check how you're doing. Because, for example, Asian women need a very low concentration of hormones.
Interesting.
Women from North Germany, they need more. So it's super interesting because there is not yet like a concentration that is good for everyone. I can say above 200, we reach like a therapeutical level that is good for cardiovascular health, is good for osteoporosis, is good for the well-being. But there are really women that need just a little bit to feel well and to have already the protective effect, and other women that need a lot.
I find it fascinating what you just shared, if I may comment, because we go back to sex and gender precision medicine that also refers to ethnicity, actually, because different type of races and ethnic groups might have different constellation, including the hormonal one that you just referred to. It's fascinating to learn that women with an Asiatic genetic background might have a different hormonal level concentration than people coming from the Caucasian. And I think that this is where the clinical development, the future of medicine should really go, going back to the work of the Women's Brain Foundation, right? It's about characterizing those nuances that are specific to men, women, but also to different type of ethnic group. Anyhow, this was just a comment of mine because I find it really fascinating. So now we spoke about when to start. We spoke when to adjust and what to adjust during the course of the treatment. I have a critical question, and here I don't know which is your opinion, but I heard different type of opinions. When to stop?
Guidelines says around 60 because we know that after 60 the hormone replacement therapy can increase the risk of breast cancer. Meanwhile, and I tell you because I just had a master class actually in June about it. The opinion are changing because we see that women are doing so well on hormones that is really tough to get rid of it. So now, like I say, my personal experience, I do it longer. So until a woman have the feeling that needs it and she's doing well on it, then I say, okay, we continue.
Of course,
But
monitoring the risk.
Exactly. We continue to do then the proper breast check. We do like systematically, like endometrium, because we know the risk of hormone replacement therapy, if it's not well done, is the endometrial cancer. So we have to check it as well. So it's important to be aware of the risk of the patient. But what I can see as well for osteoporosis is so important to also help with hormones. I can see women
Absolutely.
that have the therapy and not have the therapy. The bone density is significantly different.
And why this matters? Because we prevent fractures of our bones, and one of the most common cause of death in elderly, it is really fractures of main bones of the body, which is more often and frequent in women. This was also the result of an analysis done on the Swiss population, where women are the majority with diseases of the Bewegungsapparat, und natürlich geht mit Knochen und Muskel, und we're switching to German. Very good. So this is now the discussion about HRT replacement therapy. Before we move on now to the rest of our conversation, because we still have to discuss about why certain women have it better and why certain women have it worse, because that's the case. The question I have is also, what else shall we take into account when during perimenopause? Because it's not just about hormones only, right? I mean, there is many more things. There is iron that starts to get lower. There is our skin that starts to change, the power of vision. And with these questions, I also would like to ask you, do you suggest supplements? And if so, how one should navigate this ecosystem?
So I'm a big fan of lifestyle first. So I always ask systematically to all my patients how their diet is. I really go through breakfast, lunch, and dinner. And the more I ask and the more I recognize that women are in our society, even though they are very informed, they eat quite badly. They skip meals, they don't eat enough protein, they eat very badly. And we know, for example, I go back to osteoporosis, we know that high protein diet can also help against osteoporosis.
And is it true, I read that women going through this transformation start to have again eating
disorder?
Yeah, that's right.
Since there is weight gain, women are so afraid to put on weight, they stop eating properly. So they skip meals, as I said, they eat just some protein bars or just what they have time to eat. So lifestyle and a healthy diet. And we are both Italian, and I'm a big fan of Mediterranean diet and having like enough vegetable and fish and right protein.
This is also recommended by the Society for Alzheimer's Disease, basically, the Mediterranean diet that prevents the risk of dementia later on in life. So we go back to the axis that goes between the brain, the heart, the rest of the body, and our changes in hormones due to perimenopause and menopause. Go ahead. Just want to make this
So diet is first, and we really, meanwhile, give like a diet plan. If I see that women are...
Do you work with a nutritionist, or do you recommend also a nutritionist?
Sometimes yes, sometimes no. It depends. It depends on different factors. But if I can, and the women can also, either with the insurance or economically, like afford, sustain it, yes. Otherwise, we were, like, I also think... if I were a patient, I don't have so much time, so I try to compact as much as I can. So I give some suggestions, like with a diet plan or like together with a nutritionist. As I said, it depends. What I started to work is like with some personal trainer as well, because I recommend as well physical activity.
Absolutely.
And really tailor-made. So for women with more osteoporosis risk, they really need to do more certain kind of exercise. For others, they need more cardio, but it's part of the perimenopause program. So lifestyle with a good diet. It doesn't need to be perfect, because let's be clear, we are all super active, so you cannot control everything. And at least 3 times a week sport.
That's what I do. I'm very
glad.
And
you know what I'm recommending as well? To have fun.
Oh, yeah.
like for brain health, but there is so much being serious and so much anxiety that I say just enjoy what you're doing.
Friends, I think that the connection, the network, a coffee with a friend sometimes is one of the best therapy. And you mentioned something very interesting before we start this discussion. This was not yet when the mics were on, but you recommended to take care of our look, of the way we feel with ourselves, and you said that you recommend very often to go to a friseur, to a hairstylist. Yeah, exactly. I find it absolutely important. Maybe, do you really think that it does something to the mood of your patients?
Absolutely.
Because be indulgent with yourself when we say it's true, huh?
We are women. And it's super important to function, but also to feel women. And if you just function and you have to get up early to work, to take care of the children and run back, but you lose the essence of your being a woman, it's kind of sad for your body. And I remember once I was in Florence to a beautiful exhibition, and that was celebrating Venus. And it was like a painting where there was a woman getting ready. And
the ritual of getting ready. Absolutely.
And really inspired me a lot, because I really thought this is as well part of being a woman.
Actually, if I look back at my youth, that was really part of my human female development. You know, how long I've spent taking care of the way I would have looked nice to myself, first of all, and then, of course, to the rest of the world, because it gives you that level of self-confidence to mature through the rest of your life as either a student back then, and then a professional, and then also transform towards a new life. Some people even say change your look, because now you have different color of the hair or the skin, and you might suddenly switch from a red color you always had, starting to wear black, or vice versa. I'm just making examples.
And it's super because it's also an element of loving yourself.
Yeah.
And as well, acknowledging that our body is changing. Because there is, when you were probably 16, your body was different, your skin was different. And for women, sometimes it's super difficult to accept the change of their body. It's not just about weight, it's just the skin and so on. But if you take care of yourself in a healthy way.
I loved how the conversation is developing, because now I have a very important question. And we go back to why certain women have it easier and why certain women don't. And actually, which are the advantages of having menopause? Because if we look from an evolutionary perspective, there must be some good reason as why this is the case. I've read, by the way, that whales also stop with menstruation. There are just a few mammals, together with elephants, if I recall correctly, that do have menopause. The rest of mammals, apparently, they can be fertile and give birth till the end of their life. So what it is, in your opinion, or based on scientific evidence, is the advantages of menopause, if any?
Let's say I want to say Chinese medicine. I read recently a very beautiful book about menopause and the evolution of women. And in Chinese medicine, actually, they say that women that went through menopause are wise women. They find a balance. And if you
the wisdom
increase, and there is a stability that you can look above everyone else and you can give advice.
It resonates with me. I'm 51. It resonates pretty well with myself. Yes.
So this is for sure what I see. So women that go through menopause in a healthy way, healthy and with a lot of awareness and so on, they go to a next stage of life. And it can bring you also tranquility. It can bring wisdom. It can be like this settling down.
I also think it's something to do with the freedom. You acquire an additional level of freedom where you still take care a lot of your beloved one, your family, your environment, because women have this attitude to be more caring, let's say, because we have all the hormones that are wiring us into this direction. Let's talk about oxytocin or estrogen as well. But let's say that this level of caring, which sometimes can be also extreme, because you might want to please everybody, because you want to be considered pretty by everybody, because you want to make everybody happy and content. The lowering of estrogen, I think it gives you that level of balance and that level of freedom of the pressure that the world sometimes put on women a bit too much, if you know what I mean. We have to look pretty, we have to be mother, we have to function, we have to be professional successfully, we have to take care of our parents. So how many expectations the society put on a woman? I think sometimes can be overwhelming. So this new phase give us a new level of balance. And so this is a positive side, if any.
Yes. I can see like women that are very happy in this new phase of life. And our job actually is really to help women to go through the phase and say, okay, you know what, something is changing, but if you tackle it properly, it's okay and it's good. And sometimes it's also important to use our memory and think about our grandparents. They didn't have any awareness. They had simply to function. And anyway, they were happy afterward.
Absolutely.
And probably they became red and they had their hot flashes. But it's important as well to be aware, but not to be anxious about menopause. Because I see now a counter movement sometimes that is scary.
Interesting. That's very important. So it's still a physiological transformation of the female body that today has a different level of knowledge, luckily so we can mitigate the symptoms for those who cannot basically stand these symptoms. But there is also a certain number of women that might face this transformation very gracefully. And I know really many who told me that they didn't take anything and that was nothing for them, they even didn't realize. But I think it's very individual. And maybe that's to do with genetics, with epigenetics, with lifestyle, with how the purpose drives you further, because then we go back to the brain health, to the mental health, to the purpose that a person might have in life.
Absolutely. And for me, it's simply important to say, okay, there is menopause. How do you feel? What should we prevent? But as well, don't create a monster.
Yeah, because it's not. I think that, maybe we want to still debate a little bit about the supplements part, as I don't think we have gone through all of those helps or what one should look additionally to the hormonal changes during this new phase of the life of a woman. Maybe we want to spend a few words on this.
Normally, we recommend for sure vitamin D. Vitamin D for the prevention of osteoporosis and fracture. But we know as well vitamin D can be also good for mood.
And preventing dementia. This is also very important. No? This, again, brain.
Yes, it's all connected.
Body.
So vitamin D, number one, I will say omega-3. As well. That's very important. And then there are different supplements that we recommend, but this is very tailor-made. For example, magnesium when they have sleep disorders. And then we can do magnesium plus some herbal remedies like ashwagandha. There is an Indian herb that is really used in the Ayurveda tradition, and it helps a lot for sleeping disorder and anxiety.
What about matcha? This is another hype. What is that? I mean, can you elaborate on that?
That is like the hugest hype. Everyone is drinking matcha. I think that it's really good also for metabolism.
But it's a hype in a way, right? This is interesting because I also read recently that we have an overdose, if we might say that, or an overload of proteins. You know, we have a diet that it's too abundant in proteins. So I think it's, again, the measure is in the middle. How much you take, how much is good for you, and how much has become more of a trend, right?
Absolutely. And especially also in supplements, there is a lot of marketing behind it.
Of course.
And it's really tough also for us to really individualize the one that are really evidence-based.
Of course.
Let's be clear.
Yeah.
But as I said, there are different kind of women. There are the women that have, for example, pain in the joints. For these women, we can give chondroitin, glucosamine, that is proven as well to help a lot. Many women now use collagen, and I recommend it as well. Is evidence-based? No. But I can see a difference, so why not? It's for sure.
So there is a clinical observation from your side.
Yes, and also from dermatologists that you can see like an increase of the quality of the skin.
That makes sense. I mean, we are depleting our body of this self-production of these elements that our body will generate themselves. We are a factory, right? And the factory age. And so if you can help the factory from outside with anything that it's meant to be beneficial, staying, of course, very well, active, physically active. Sometimes, I've said it also in another recent podcast, what I often recommend it is walking. There are people who don't like to do sport, they have no time to do sport, no money, or they have a physical condition that does not allow to do sport for whatever reason. Walking.
Walking is amazing. And actually, we were speaking before about lifestyle. So I recommend a lot, like sport and as well walking. But especially if we go back to our population of perimenopause and menopausal, they need a little bit more. Walking is not enough because many women say, yeah, but I'm walking.
No, but when I mean walking, you're absolutely right. I mean, walking, 2 hours of walk per day in a very, let's say, good rhythm. It's not about when you move in the house up and down. This is for me, of course, no walking.
No, but you need also sport like with strength training.
Absolutely.
We know for muscle health and bones health, we need it.
Absolutely. I think it's also to prevent the risk of falling down. This is also super important, to do sport activity that teaches you how to fall. I find it fascinating. I have my sport trainer. She really does part of the 1 hour lesson on how to learn to fall, because we start to be more prone to falling when we get older, and to learn how to manage in this situation might prevent you from a very bad fracture or a brain trauma that might have the very bad consequences.
Because it's interesting, because with aging, our balance sense is changing. And going back to menopause symptoms, even though it's not written yet, I have many women that start to experience tinnitus. And that can be also related to hormone depletion, because the water in the ears is changing, and that as well is something related to balance. Tinnitus, like with our ear system. So there are so many things now. We could speak hours and hours about.
Absolutely. But it's all interrelated. It's fascinating, and I think it is time that we take also this part of our life into control. Okay, so maybe before we go towards the end of this very enlightening conversation, where myself I've learned a lot, and I think I have to change a few little things in my life here and there, but it's not too bad. I think that I have to come with another a bit controversial topic, and this is about testosterone. Now, hormones are to be found everywhere and can be easily prescribed. What about testosterone and perimenopause, and what does testosterone might do versus estrogen and progesterone?
So what I see a lot in perimenopause and menopause is as well sexual changes. So many women may experience like a lack of libido and sometimes a lack of motivation. So the big question is, can testosterone help or not? And many women really ask for it, or ask at least, can you please check it? So meanwhile, we check it, and we check not just testosterone, but also DHEAS, DHEAS, both of them, and sometimes they are lower. So we can now also prescribe, in some cases...
What does testosterone does, actually?
Actually, like estrogen is all over our body, so it has as well a receptor in our brain and can really increase like the motivation or our drive. If given too much to women, studies have shown that can also make women more aggressive.
And anxious, right?
Anxious as well. Yeah. So it's super important also to dose it properly. In Germany and Switzerland, there are not... testosterone gel, because we do testosterone as estrogen in gel form. There are not the testosterone made for women with low dosage. That's very interesting. Too high dose. So we really have now to work either with the testosterone that are available on the market and really tell to the women, please put 0.5 centimeters of this gel in order to dose it right, or meanwhile there are also pharmacies that do it on demand.
Oh, very interesting.
Yes.
But I have to say, Valentina, that I am 51 years old. I've studied medicine quite a while ago, and from the day I remember I've been studying menopause at medical school, and today I'm very pleased to see that a lot has changed. We know much more. We can do a lot to actually navigate this phase of our life. So for me, it is like, medicine is really advancing and moving to a fast pace forward to benefit everybody. I mean, men, women, and above all, the entire society. One remark I'd like to do is that we're working together to create a questionnaire that will check really the brain health and all what we discuss of the women out there. So to create this interconnection between brain, the heart, the reproductive system. So this is a work that the Women's Brain Foundation is currently doing, also thanks to your contribution. We are very, very pleased about this. And we are arriving to the roundup of this conversation. conversation. What I also would like to share with our listeners is that we have established a newly founded academy at the Women's Brain Foundation where people can join and learn from experts like you, like the other colleagues that are affiliated to the foundation, what it's about sex and gender precision medicine. And it's about menopause, perimenopause, fertility. It's about longevity. It's about brain health, mental health, and neurological disorders, etc. Thank you, Valentina. It has been great, this exchange with you, and we truly learned a lot.
Thank you, Antonella.
Thanks a lot.
Thank you.
Bye-bye.